Okay, good morning. It's wonderful to be here today, and I thank the organizers for this opportunity to be with you and to share some research highlights from DDW. So let's start with the Precision trial, which was a study of the efficacy of personalized dosing of infliximab in patients who were started on the biologic therapy and its efficacy on clinical outcomes. So the premise of the study was that preliminary evidence has shown that therapeutic drug monitoring, as well as dose adjustments or optimization, could improve clinical outcomes in response to therapy with the use of infliximab. These Dutch investigators, therefore, used a, whoa, I just pressed it once, and we're done. That was very interesting. I just pressed it once, I promise. Wow.
Use the red and green button, please. The one right above.
Can I use a keyboard maybe?
There should be a red and green button that is right above the mouse. The one that says forward and the one that says reverse.
Yeah, that's what I'm pressing.
Stand by. We're setting you up again.
Okay. Can I proceed? Okay, great, thank you. So these investigators from the Netherlands used a dashboard, which was a clinical decision support tool, to predict the trough levels for infliximab based on a pharmacokinetic model. And what they then did is, What they then did was basically randomize patients to either having this personalized dosing versus the conventional group. And the personalized dosing mechanism would actually predict or try to predict the trough levels and target 3 micrograms per milliliter of dosing of infliximab versus in a conventional group where they actually had no dosing adjustment. Their outcomes at the time was either clinical remission, response, or loss of response, and also biochemical markers such as the use of fecal calprotectins and CRP. The patient demographics between the two groups were actually fairly identical. Naturally, they were randomized. And when they actually looked at the outcomes, they actually did show that using a per-protocol analysis, that personalized dosing was more efficacious than conventional dosing for the achievement of maintenance of clinical response after 1 year. The challenge with that, however, is that they use a per-protocol analysis. So as you may be aware, that when we actually do analyses of clinical trials, what we want to do is do an intentional to treat analysis. The difference between the two is that in an intentional to treat analysis, what you do is you basically look at what are the outcomes for all those individuals who are randomized to a specific arm versus what are the outcomes for those who just completed the study. So that's the former is intentional to treat analysis, and the latter is the per protocol analysis. And when they actually did, I'm going to show you the per protocol analysis. They again showed increased efficacy for personalized dosing for maintenance of clinical remission. But then when they actually did, when they did intentional to treat analysis, they did not actually find a difference in terms of clinical remission by 1 year. And I would actually like to note over here that if you looked at the top group, the personalized dosing group, they actually had 3 individuals who were found to have an opening of their fistula tract. And this may have been why they had a difference in, or no difference in a clinical remission between the two groups. The difference between the proportions being 30% versus 37.5%. And when we looked at biochemical and clinical remission, we actually find that personalized dosing was superior at achieving a higher proportion of patients with clinical remission and a fecal calprotectin less than 250. So in conclusion from this particular study, they showed that dashboard-guided dosing, so again, their personalized dosing tool, resulted in higher proportions of patients being able to achieve clinical and biochemical remission. But I did point out some of the nuances in their interpretation, which they tried to de-emphasize, was the fact that number one, they were using per protocol analysis, and number two is that they actually had higher risk of causing reopening of the fistulae in the intentional to treat analysis group. And so they then hypothesized that because of these reopening of the fistula, maybe 3 micrograms per milliliter of infliximab might be too low of a trough level. But that is another study. Now, moving on to the UNIFI study, which is a study of ustekinumab in ulcerative colitis, we do know that ustekinumab is FDA approved for the use in Crohn's disease. And so now, fortunately, there are efforts to try to get it approved for ulcerative colitis. Now, the prior studies have actually looked at it for the efficacy in induction of remission. So this particular study tried to look at it in terms of maintenance of remission. So for those individuals who had clinical response to the IV ustekinumab and achievement of clinical response, they then randomized these individuals to one of 3 arms, either the 90 milligrams sub-Q every 8 weeks, which is what we know as the standard dose for Crohn's disease, every 12 weeks, which is the standard dose for psoriasis, and placebo. And the endpoints, again, were clinical remission, steroid-free clinical remission, response, as well as endoscopic healing. The disease characteristics between the 2 groups were fairly similar, again, after randomization. But then when we actually look a little bit deeper, particularly at the discontinuation, we find that those in the placebo arm tended to be withdrawn from the study more readily. Not surprising. And the reasons for that included worsening of their ulcerative colitis and perceived lack of efficacy. Otherwise, we don't see any differences with the ustekinumab group. Now, when we dive into the results, clinical remissions, and for clinical remission and corticosteroid-free remission, we see that ustekinumab was superior to placebo at both the Q8 and Q12 week dosing. For the stratification of patients who actually had prior use of biologics and failed it, we find that still, regardless of whether you failed or did not fail prior biologic therapies, ustekinumab was again shown to be superior to placebo. And for those who actually had biologic failure, approximately 40% of them were able to achieve clinical remission by 1 year on the Q8 weeks of ustekinumab. In terms of maintenance of the clinical response as well as symptomatic remission over time, we see that for the purple lines, you see on the illustration to the right, that they actually had maintenance of symptomatic remission while on the ustekinumab arms, whereas those on placebo had a decrement of symptomatic remission over time. And we also see similar trends for endoscopic and histologic improvement. When we looked at fecal calprotectin, we see that naturally everyone had a decrement in their fecal calprotectin prior to enrollment to the study, because again, inclusion criteria were those who responded to ustekinumab. But then what happens when they actually were followed through beyond that time? Those who actually remained on ustekinumab had either a maintenance or a decline in their fecal calprotectin levels, whereas those who actually received placebo had an increase in their fecal calprotectin levels, at least the median of fecal calprotectin concentrations. In terms of safety findings, we do not see any difference between ustekinumab and placebo or any increased risk of any adverse events. So in conclusion, for this particular study, we find that ustekinumab is actually helpful for the treatment of moderate to severe UC, and there are no increased signals or safety events. Moving on to the next drug class, the sphingosine 1-phosphate receptor modulators. And the S1P receptors play a role in lymphocyte egress. So presumably by inhibiting this, you're able to have a theoretical reduction in systemic inflammatory response. So this particular study looked at the use of a new novel compound for Crohn's disease, and later I'll show you one for ulcerative colitis. So the one for Crohn's disease was Amiselimod, and preclinical studies in animals had shown it to be effective for IBD, psoriasis, multiple sclerosis, and lupus. Now, what does it mean when we translate it into humans? So for this particular study, they randomized patients to either Amiselimod, 0.4 milligrams per day, or placebo. And the outcomes were, again, the standard outcomes of response, remission, and so forth. The randomization did create an equal distribution of patients on both arms, and interestingly, there was actually a balance of loss to follow-up as well. Now, when we actually dive into the results, we actually find that Amiselimod, unfortunately, did not actually meet any of its primary or secondary endpoints, and there was actually no difference between Amiselimod and placebo. So the investigators concluded, unfortunately, that their dosing of Amiselimod at 0.4 milligrams per day was not effective for the induction of remission or response in patients with Crohn's disease. But what about ulcerative colitis? There's another sphingosine 1-phosphate receptor modulator called Etrasimod, and there were previous studies that showed it to be effective for induction of clinical response, remission, and improvement in endoscopic appearance and the levels of circulating lymphocytes. So for this particular study, they went the next step further by trying to look at histologic remission and mucosal healing at week 12. In this study design, they randomized patients to either 2 milligrams of Etrasimod, 1 milligram, or placebo, and the endpoints included endoscopic improvement, histologic improvement, remission, and mucosal healing. In terms of the results, they actually find when compared with placebo, Etrasimod at 1 milligram was actually not any different in achieving endoscopic improvement, histologic remission, or mucosal healing. However, at 2 milligrams, we actually found that it was able to significantly increase the proportion of patients who actually had endoscopic improvement, histologic improvement, remission, and mucosal healing. So they concluded then that Etrasimod 2 milligrams per day was effective for inducing higher rates of endoscopic improvement, histologic remission, and mucosal healing. So that rounds up pretty much some of the breaking abstracts at DDW in the topic of IBD. So I'll just present an overall summary of what we have discussed thus far between Dr. Higgins and myself. So for one, we saw from the Puccini study that preoperative use of anti-TNFs should not affect surgical decisions for IBD. Dr. Higgins had also presented from the Varsity study about vedolizumab showing superiority in achieving clinical and endoscopic efficacy, but not, interestingly enough, steroid-free remission, and Dr. Higgins had shared his thoughts on why that may be when compared with adalimumab for the treatment of moderate to severe UC. We also see that there's a novel anti-P19, the mirikizumab, which was effective for induction of remission in Crohn's disease, and it also has had prior efficacy shown in ulcerative colitis. And when we looked at precision dosing of infliximab, we found that it to be superior to conventional dosing for maintenance of remission, but with the caveats I mentioned earlier. Ustekinumab is also, fortunately, safe and efficacious for induction of clinical remission, maintenance of clinical remission, and achieving endoscopic histologic improvement for moderate to severe UC. And when we looked at the sphingosine 1-phosphate receptor inhibitors, we found that unfortunately for Crohn's disease, Amiselimod was not effective, but for ulcerative colitis, Etrasimod at 2 milligrams, not 1 milligram, was effective for endoscopic improvement and histologic remission and mucosal healing at 12 weeks. So what do these data show? So on one hand, in terms of the drug pipeline, there are certain drugs that hopefully will be coming out in the next few years. So for Crohn's disease, we have presented some data on mirikizumab. And for ulcerative colitis, there too are some data on mirikizumab as well as ustekinumab, which we already use now for Crohn's disease, and then hopefully in the near future, Etrasimod as well. So with that, I thank you for your time.